Сегодня мы с вами гуляем по треку «Сбор данных. Гид по выживанию», который будет интересен всем, кто хочет научиться сканировать, выполнять постпроцессинг, собирать данные, в общем, всем-всем-всем. Если по какой-то причине ваши знакомые рентгенологи и рентгенолаборанты еще не подключились к нам, немедленно позвоните им, напишите, отправьте почтового голубя, чтобы они не пропустили следующую сессию, потому что мы получили огромное количество заявок после прошлого форума. Пожалуйста, расскажите о том, как сканировать нервы, как выполнять МР-нейрографию. Со мной в студии профессор Игорь Николаевич Пронин, который является президентом Российской ассоциации Российского общества нейрорадиологов, и мы с ним ждем в эфире, появится у нас чуть-чуть попозже, Густав Андрейсик. Густав Андрейсик из Цюриха, он является, собственно, автором книги по МР-нейрографии, читает огромное количество лекций на ИСИАР. Несколько лет назад у него был замечательный мастер-класс в Санкт-Петербурге. Очень завидую всем, кто смог его посетить. Я была, собственно, среди этих счастливчиков, и мы узнаем все об этой методике. Но прежде чем мы посмотрим обстоятельную лекцию доктора Андрейсика, кстати, напоминаю, что вы можете просто кликнув на иконку «Ру» или «Инг» слушать либо синхронный перевод на русский язык, либо оригинальную звуковую дорожку на английском. Но перед этим, Игорь Николаевич, скажите, почему нейрография пользуется вообще, или это, может быть, только наши слушатели такие заинтересованы? Вообще, эта методика, насколько она применима и насколько на нее есть запрос?
Ну, прежде всего, я хотел поблагодарить за приглашение принять участие в таком интересном, наверное, митинге, да, и вас лично, Ирина Анатольевна. Сама тематика, на самом деле, нейрография, она уже не новая. Конечно же, с момента появления МРТ всегда была попытка визуализировать не только для чего предназначена МРТ, это головной мозг, спинной мозг и другие органы, но там, в частности, и те структуры, которые всегда оставались, скажем так, на стороне, за пределами возможностей первых МРТ-томографов. Конечно, как нейрорадиолог, я больше занимаюсь поражением центральной нервной системы, и нейрография там очень очевидно и ярко представлена в так называемом нейроваскулярном конфликте, когда нерв сдавлен артерией, и тяжелейший болевой синдром является очень мучительной ситуацией для наших пациентов и требует хирургического лечения. Но прежде всего нужна постановка диагноза, прежде всего. Конечно же, с появлением новых приборов, новых специальных катушек и, главным образом, появлением новых импульсных последовательностей, которые смогли оттенить движение нерва в любой области его локализации, расширились возможности этой технологии. И одним, может быть, из первых было исследование поясничного и плечевого сплетения, как ближе всего к центральной нервной системе. Но на самом деле современные возможности МРТ позволяют видеть практически любой нерв. Поэтому сегодняшняя лекция для меня тоже будет интересна, так как она в более широком аспекте охватывает эту проблему. И очень важный аспект в этой лекции наверняка будет не только клиническая ситуация, без которой нельзя, конечно, разбирать любую патологию, но и главным образом те методологические аспекты и те технологии, которые необходимо применять для того, чтобы увидеть нерв. И увидеть не только его, но увидеть и патологии, которые вызывают те или иные синдромы. Поэтому я с огромным удовольствием тоже готов присоединиться и слушать. Если она готова, то мы с вами будем внимательно смотреть за всем, что происходит на этом экране.
Thank you very much for the invitation for this presentation. In the next 40 minutes, I will talk about MR neurography, role and impact of MR imaging on patient management. These are my financial disclosures.
На данном слайде
I'm very happy to give this talk, despite I'm quite far away. At the moment, I'm in my hospital office, which is located just in the north of Switzerland, close to the border of Germany.
Уберите, пожалуйста, дорожку переводчика.
Спасибо. We have a nice sunny summer day today.
Переводчик не слышит аудио. Переводчик не слышит аудио. Переводчик не слышит аудиодорожку. Аудиодорожка не работает у переводчика. У переводчика не работает аудиодорожка. Перевод невозможен. Аудиодорожка не работает. Аудиодорожка не работает, перевод невозможен. Аудиодорожка не работает.
Equipment, and we see about 160,000 patients per year in radiology only. This is the structure of my talk. First, I will talk a little bit about MR neurography in general and current perspectives. Then we will have a literature review, as well as I will show some practical cases which illustrate the impact on patient management.
соответственно, добавить звук. Вот, собственно, это.
Peripheral nerve imaging is often referred as MR neurography or in an abbreviation MRN. It's imaging of peripheral nerves with excellent anatomic capability, and it has seen rapid improvements due to coils, sequences, and software in the past years. There are some quantitative functional MR methods as potential biomarkers available, but the clinical standard is high-resolution 2D and 3D imaging. This is the front page of a book which I wrote together with a colleague a couple of years ago about this topic.
Если вам интересно, потом можно сделать экскурсию. Просто скажите ассистенту.
There is a clinical need for MR neurography because the incidence of peripheral nerve lesions might be quite high. In some countries, 5% of the population has a form of neuropathy, and 5% of trauma patients have an injury of peripheral nerves. The clinical evaluation is based on electrodiagnostic tests, which can be sometimes not conclusive and sometimes insufficient due to the dependence on target innovation. In addition, new research, new surgery techniques, as well as new regeneration enhancers, such as nerve conduit, stem cells, nanotechnology, are under development and need precise diagnosis prior to their use. The challenges of peripheral nerve imaging is, despite there is increasing awareness among radiologists, there is still a lack of knowledge of this technique among general physicians. In addition, in some countries, I see a turf battle between different subspecialties, such as neuroradiologists versus musculoskeletal radiologists. I personally think this is stupid. This technique should be done by the best available people, but nevertheless, that's what I observe. A huge problem in some countries is lack of reimbursement, so we don't get paid for what we do. And in even some other countries, I see also a problem that MR neurography is outspreading quite rapidly to so-called non-specialized imaging centers, so basically radiology departments without specialization. And this is a problem for such a highly developed technique. Not everybody can do it. It needs proper training and some experience. In our hospital, MR neurography is daily routine work. We perform basically imaging of all nerves. These are some numbers, so you can see there's a steep increase in numbers in the clinical routine every year. And it has really been a highlight of our imaging department in the past 3 to 4 years. We also get attention from clinicians far beyond the borders of our region. A big problem is the referrals. How do you get as a radiologist good referrals? First, as I told you, the clinician must be aware of the technique. Once they have understood what we are capable of doing, then you will get much better referrals than just without education. It's very important that the clinicians limit the field of view where we are going to image and to limit the differential diagnosis. It makes no sense to just send the patient to MRI and let's look what you can find. That's not the way it works. I even prefer if the referring physician uses all techniques, including pre-MRI ultrasound, to narrow down the field of view and the differential diagnosis so that I can focus very much on what is needed for each individual patient. So focus, 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 and then the MRI technique will be perfect. In our hospital, we have a team. We have a surgeon, a neurologist, and me as the radiologist, and we work closely together and we discuss all patients' all the time so that we get the best out of each exam. The problem of referring patients to radiologists and to providing good clinical referrals has also been detected in other countries. This is an example from Brazil, where Dr. Rodrigues de Abreu made a website for referring physicians so that they can basically click and ask the radiologist the right questions for their patients. So this is quite helpful so that we can really focus our MRI on each patient individually. For didactic purposes, I always distinguish between different types of imaging. First, I think there is anatomic non-selective imaging, which is basically high-resolution 3D imaging of an anatomic region. You can see this is an amputated lower leg, and at the end of this nerve here, you can see a neuroma, very nicely depicted on these high-resolution images. This is basically what can be done in all MRI scanners. Then there is anatomic nerve-selected imaging, which means that you acquire images which are specifically determined to image a specific nerve. Usually this involves the use of a diffusion-weighted sequence such as 3D DWI PSIF. It's a sequence which suppresses vascular signal, and unfortunately it's behind this video, but you can see that all these vessels are now not seen, but you can see only the nerve itself. I try to highlight this. Here you can see this is the nerve, and here there are all these vessels. The imaging technique is not that difficult. You can use traditional T1, T2 sequences, fat-saturated sequences. You can use 3D sequences, space-stir, PSIF. You can use echoplanar imaging, which is basically a diffusion-weighted imaging, or DTI. And you can use contrast-enhanced imaging. That's not particularly novel. But it's robust and it takes you through the daily routine. What I always recommend is to use the best technique and hardware available in your department. So you may put the patient in a 3 Tesla scanner, you use the best gradients, you use a homogeneous B0 field, you position the patient properly, and you try to acquire good images without any artifacts. This is an example of a patient who has a chronic inflammatory neuropathy. You can see massive thickening of the nerve roots. This was acquired with a 64 channel on a 3 Tesla machine, and I think this is a stunning image quality. Coils are very important when you do MR neurography. Here are some examples. This is Philips, GE, Siemens, Canon. Independent of what you are using, you always should try to use your best coils available. And if possible, you can also buy coils specifically for the purpose of nerve imaging. Large coils are very helpful in the extremities to cover a long distance over the leg or arm, as you can see here. And this is very helpful, as you will see later on in the clinical cases. There are also new sequences available which were specifically designed and developed for nerve imaging. For example, this sequence, which is called 3D Shinkai, it was developed in Japan, and you can see there are the nerves of the plexus visible on both sides excellently. This sequence involves fat suppression using a spare pulse, vessel signal suppression using a technique which is called IMSDE, and it's basically a contrast-efficient T2-weighted 3D rare sequence which uses variable flip angle technique. This sequence was bought by Philips and it's now marketed by Philips under the term 3D nerve view. So it's basically a sequence which you can buy from Philips when you have a 3D or 3D scanner from Philips. That's where it works best. This is an example. I try to start this movie. This is a clinical routine case. You can see the quality of the images. I try to stop. Now you can see here the nerves of the plexus on both sides. I will restart the sequence. Again, I stop, and now you can see the different fibers of the plexus here on this left side, but also on the here on the right side as well as on the left side. It's very easy to see all these fibers once you have good image quality. I also start this movie. This is a DWI sequence. It's a 3D data set which shows you the diffusion within the brachial plexus. As you can see, it's a perfect image quality. These dots here are all lymph nodes, so don't be confused. But it's really perfect to see the diffusion within the brachial plexus. You will see later that this diffusion images is a representative of the function of the nerves rather than just anatomy. I also acquire 3D datasets which allows multiplanar reconstruction in every slice and a plane I want. You can see these are the coronal acquisitions. These are axial and sagittal reconstructions. That's sometimes quite helpful. Once you use advanced software, you can merge anatomic sequences together with diffusion data sets. Here you can see a colored overlay. This is basically an anatomic sequence plus diffusion sequence. And the color here means the diffusion, and the gray scale image is the anatomic sequence. So basically you can compare anatomy and functional imaging on one slice and one image. In the literature you will find even more sequences proposed for nerve imaging, but to my personal experience they don't work well. Sometimes I have to adjust my imaging to the individual needs of the patient rather than just performing a standard protocol, which I always try to prefer. This is in German language, but you can see that I have written here that I was using a standard protocol, but then I adapted it to the specific needs of that patient because I could not find any pathology on the standard protocol. So this was clinical routine. Let's move on to functional nerve selective imaging, which goes beyond anatomic imaging. Functional imaging means specifically that we perform diffusion tensor or diffusion weighted imaging. You may remember to the days of the school where you learned about the Brownian motion of atoms or molecules, where you have learned that these atoms and molecules move around quite randomly in the room. If you trace the movement, then you will get an image or figure like that. And our situation is a little bit like a glass of water where we put a straw. So the straw is basically representing our peripheral nerve within a tissue or an arm or leg or something like that. Within that straw, the water molecules, they move up and down in the straw. So we give the motion of the water a direction. So we have a directed motion. So the movement of water molecules or molecules at all along a peripheral nerve is 3 times higher than across a peripheral nerve. So our peripheral nerves allow diffusion along the longitudinal axis of a nerve rather than across a nerve. And that's what we can see in imaging. We call this situation anisotropic diffusion. With diffusion imaging, there is also involved some quantitative parameters such as FA, fractional anisotropy, or ADC, which is apparent diffusion coefficient. This is the equation of our signal, and here you can see that there is a factor which is called the D factor, and that is basically ADC. You can also see the B value here, which is a value which you can adjust on your scanner. And once you acquire your data set, then for each single voxel you get 3 information about the diffusion within that voxel. Lambda 1, diffusion along our axis, lambda 2 and lambda 3, diffusion direction in this axial plane. So for each single voxel we know, based on this equation, the main diffusion direction of molecules. Remember the sequence which we use for diffusion tensor imaging, which is echoplanar imaging. It's a spin echo type sequence where we have an excitation pulse and an inversion pulse of 180 degrees. In the situation where we have a free diffusion, so glass of water, molecules can move around without restriction. We perform the excitation pulse, and then the molecule diffuses out of our imaging plane, which means when we acquire the spin echo, we will have a decreased signal because all the molecules are out of our imaging plane. In the situation where we have a restricted diffusion, so basically within our straw, the molecules will stay in plane, which means when we acquire our signal, we will have an increased signal. This is very well known from brain imaging. When the diffusion is high, we have a low signal. When the diffusion is low, we have a high signal. Let's remember a stroke, for example. Restricted diffusion means high signal. How can we illustrate the diffusion direction? First of all, we have this color-coded possibility, so we give colors to the main diffusion direction. Or we use these small vector diagrams where we can see that within a brain, this is a coronal image of a brain, in each voxel we have a specific direction of motion. So when we combine these little arrows, then we get tracts, and that is what tractography does. So we combine the little arrows of this diffusion sequence, and then we get images like that from the brain, which is tractography. That can also be here the wrist, and then we go up and down and have this nerve illustrated. We can also do this on the lumbosacral plexus. Let's say this is the sciatic nerve This is the lumbar spine, and then you can also follow these nerves along a distance. So let's summarize. So in the clinical routine, we use our best scanners and calls, we tailor our protocols, we teach our staff and the referring physicians. We perform standard sequences, and in special cases or in research, we perform also DTI and tractography. Very important is that you know your anatomy. Those nerves are very tiny. This is, for example, the nervus ilioinguinalis. It's very tiny, and once you go to axial planes, you need to follow the nerve. This little thing here, that is the nerve here on the left-hand side. This point or this point. So you need your anatomy. I always recommend online atlases, but you can also use textbooks. The most important thing is you know your anatomy. This is for a coronal image. This is the lumbar plane. This is the sacrum, sacral joint. This is the S1 nerve root. You have your lumbosacral plexus. This is the nervous, the sciatic nerve, and this is the portion of the peroneal portion. This is the portion of the tibial nerve portion. So this is a nice overview of the plexus. And when we go down the leg, we will see always the contribution of the different nerve roots on the different levels. For example, if we perform a cross section here, then we have our sciatic nerve here, and the L5 part, it's always up here and up here. So the S1 part, it's always back here. So this is S1 here. So within the sciatic nerve, we have a so-called somatotropic fascicular organization, which we can image. This is a patient with a L5 nerve root compression. This was a patient with a S1 nerve root compression. This was a healthy control patient. So a healthy control patient. And this was a patient with a polyneuropathy. In these cases, you see the nerve roots are individually affected here, without which involves S1 and L5 roots. You also need to know your diseases. For example, this case here is a very clear and pathognomonic image. It's a patient with so-called chronic inflammatory demyelinizing polyneuropathy. It's pathognomonic. It does not have any differential diagnosis on imaging. Very clear case. You also need to talk to your surgeons, because sometimes they perform strange surgeries. For example, here they connected a nerve of the upper arm to another nerve. So it was a so-called oberlin transfer surgery. And this is our postoperative imaging, which you won't understand if you would not know what surgery they did perform. Important is that we also look on the muscles. We always deal with motoric nerves, and they innervate into the muscles, so we have to evaluate the muscles. So always look on nerves and muscles together. Which brings us to image interpretation. It's always important to identify the anatomic region and the nerve, so we use anatomy, and then we describe the nerve abnormality, but we also look on the innervated muscles. Is the signal normal, and is there already atrophy? As you can see here, very important to look for. We try to use a grading system, such as neuropraxia, axonotmesis, or neurotmesis. So we try to speak the same language as our neurologists are doing. For me, important is that we can catch pathology very early on. For example, MR nerve hyperintensity occurs at day 1 if there is pathology. For example, spontaneous activity in electrodiagnostic testing is later on. So we have we can be very sensitive in the first day of a pathology. The abnormal T2 signal usually starts very early on, day 1 after injury. Then we have a plateau, and then it's going down again. So we have a normalization of signals after a couple of weeks. This was an interesting study performed by colleagues from Germany. They looked on the nerves of rabbits after they transected the nerves. So in the beginning, the nerves looked normal, and already at day 1, they saw some destroyment in the nerves. There were some macrophages coming in, and already on day 2, the nerve looked completely different in histology compared to the beginning. Interestingly, here, after 12 weeks, the nerves try to regenerate and look almost a little bit normal again. So nerves have some capability to regenerate. This is an overview of the sequences and the signals we see in terms of time, which means acute changes, subacute changes, and chronic changes for nerves and muscles. There is some variability in between, but generally we can say that there is hyperintensity on T2 in the early phases, and there is less T2 signal in the late phases. One thing to remember is try always to get as much clinical information as possible. Never make a clinical radiological diagnosis without knowing the clinical details. For example, this was a patient with a fibrolipohamartoma. As you can see here on these images, there was a lot of fat of the median nerve and ulnar nerve at the level of the wrist. And you would never be able to diagnose this clinically without having this MRI picture. This was a patient with microdactylia of the 4th digit. We try to provide a structured report where we describe nerves, the muscles, as well as the vessels, other structures, and then we give the impression of what we see and try to communicate in the best possible way to our clinician. This, for example, is a report which I did a couple of months ago on a patient referred to myself. It's also important to make the findings visible to clinicians because the nerves are really tiny. So once you have pathology here, you need to highlight it somehow and at least make an arrow so that the clinicians can see on these multiple images where the problem is located. You can also use, for example, in this schwannoma case, these nice reconstructions. This is basically a Siemens software here, which shows you this schwannoma very nicely on an MRI image. A very advanced technique. So this was the first part of my lecture. We will go on to the literature review. This was a review done today. I used the terms MR neurography and MR imaging of peripheral nerves, and you can see there are multiple publications out there, and it's already quite hard to keep the overview. What we can see is in the literature that for clinical application, MR neurography is established. The problem is still with diffusion techniques. FA and ADC, they show specifically changes in peripheral nerve neuropathies, FA is typically decreased and A is typically increased. Is FA a biomarker? We think so, based on the current literature. For example, this is a rabbit study, and it was shown that with nerve regeneration, we have an increase of FA values, which was quite much correlating with the pathology of the nerve over time. So FA seems to be a good biomarker for the future. This was proved by another rabbit study, and it was highlighted in the literature a couple of times. However, in the clinical routine, DTI measurements are not standard so far because they're technically demanding. If you want to read literature, I can recommend some of my own literature, which is more clinically orientated, so for the daily practice. So if you have problems to access it, I can also send it by email if you like. In the next minutes, I will show you some practical cases and discuss the impact on patient management through these cases. Case 1. This was a patient last year. He is doing this horse carriage activity in his vacations and spare time, and he basically fell off. So at once, and he injured his left arm. So this was the patient. You can see the left arm is basically hanging down. There was no abduction or elevation possible. He has even a reduced motion, and the reflexes were diminished and reduced. And he also had a hyposthesia over the deltoid muscle and the radial part of the arm. So he was examined by our neurologists, and they came up with problems and suspected that there was a problem of the axillary nerve, maybe also of the suprascapular nerve, as well as some other problems. But it was not clear if it was a nerve root problem or it was just a problem of the lateral plexus. So the colleagues recommended MR neurography in this case. So we performed a plexus neurography in this patient, and you can already see that on the left-hand side here we have a massively enlarged nerve root on the left-hand side, which was not on the right side. So I show you now sagittal slides. So this is right, and this is left. And so this is T1, 8, 7, 6, 5, and this is maybe 4. And here you can see 1, 8, 7, 6, 5. Yeah, and I don't know here where 4 is. So there was massive enlargement of the nerve root on the left side, especially here and here, but also a little bit here. So, and this is a classic sign for traction injury. The nerve roots are in continuity, but they are massively enlarged after trauma. This is a screenshot of what we do in plexus imaging in our standard protocol. We have a T2 sequence, a term on the left side, a term sagittal on the right side, this space stir sequence, a T1 coronal sequence. We perform always a twist angiography, doing some subtraction imaging, and then we perform usually always post-contrast fat set on the right side and on the left side. And then we do some reconstructions. So what is the value of MRI? Well, I myself did a study where we evaluated the impact on the patient management, and we saw that there are clinically unclear cases, and in these cases, the etiology of a nerve lesion was revealed in 26 of 28 cases. The site and number of lesions was basically revealed by MRI in all cases, and where both was unclear, MRI could still help in 13 of 16 cases. So the additional evaluation of the nerves by imaging is a great value for clinicians, and this was actually evaluated by our hand surgeon and plastic surgeons. So it's not my own judgment here. Other studies, such this one from Germany from 2018, support the high value of MR neurography. Second case. This was a patient who had a gunshot. So the bullet entered the left arm and basically went through here, and this was the exit point. So I did an MR study, and then I used a pen, and then I drew a marking, and I said, well, here is the plexus damage. Let's look on the images. So this is the plexus of the patient. I made the X here, and you can see that there are some fibers coming down, and then here we have a problem. The fibers are not in continuity anymore. So this was the problem for me, and I marked this as a point, and I directed the clinicians, and then they went in, did the surgery, and replaced that nerve. Next case. This is a tumor patient. You can see it. This is the tibia. This is the fibula. This is the lower leg. And then we have a tumor here. You can see on the ADC maps that this is a high vascularized tumor. And then we also performed this MRI study where we used tractography to see where the tumor, if there are some fibers around the tumor left, and we could see that there are some fibers which are running around the nerve. So it was helpful to really evolve the tumor from the nerve and preserve that remaining fibers. Next case. This was a patient who had a cryoablation of a osteoblast at the tibia. The problem was that the access pathway with the needle was straight through the peroneal nerve, which was here. So here was the peroneal nerve, and the surgeon who did it put the needle through the nerve. Patient had a drop of the foot afterward, and the question was, is there a potential for recovering of that peroneal nerve? You can see that we performed this study, and this was the tibial nerve, this was the peroneal nerve, and we could see that at the site of the lesion there are some artifacts here, but there are still some partial fibers which could recover. And that was also the fact. After 6 months, the patient recovered partially and could use the foot again without any surgery. This is a patient with a cubital tunnel syndrome. So basically here at the arm, you can see there is osseous spur. This is the nerve. Then we have the nerve here. So this is the nerve. This is the osseous spur. And so you can see also there is increased signal. This is basically the diffusion map of that ulnar nerve. You can see exactly that where at the cubital tunnel there is an alteration of the diffusion, which means the function of the nerve is not correct anymore. Next case, case 6 and 7 are together. These are examples for tarsal tunnel syndrome. In this case, we had a mass lesion, so a ganglion, which affected the tarsal tunnel. So we have a second case here. This was a postoperative complication, a fracture of the calcaneus, and they put this screw in here, and the screw was too long, and there was also this osseous spur. So once we have this problem of the screw here, here we have the screw, and then we have the osseous spur, and then we have our nerve here, and here you can see that the nerve had a problem. Second last case, case 8, a perineal nerve, sural nerve. You know the anatomy of the sural nerve. This is a case where we imaged the whole lower leg. You can see here gastrocnemius muscles. Then these little points here are the superficial nerves, including the sural nerves. You have to follow them. So you keep your eye on these small dots here. These are the sural and superficial nerves. And this patient has had a Achilles tendon surgery. I will stop that in a while. And then you can see that when they did the surgery, they also injured the nerve, which is a known complication of Achilles tendon surgery. Now we are here. The nerve is already in here. And now I will stop that sequence. Yeah. And you can see that there was the surgery performed, and there was also scarring of around the Achilles tendon, which involved the nerve. Second last case is a false negative case. This was a patient who had a surgery performed in an outside hospital of the radial nerve. This is the upper arm. You can see that the radial nerve runs around the humerus here. And the question was, why was this nerve here? Here are the nerves. You can see there high signal. Why are these nerves damaged, or is this nerve damaged? I could not see anything here on these images, and I said to the surgeon, no, I have no idea. What happened? The surgeons operated and they found this here. So they found a suture on the nerve. So the previous surgeon made a mistake and put a suture on the nerve, which basically caused the nerve injury. They did a repair multi-cable grafting of the suralis nerve, using suralis nerve here in this upper arm. Last case, very frequent pathology, externeuropathy, you should know that. So this is the ankle, this is the fibula, this is the tibia. There's the nerve coming down, going around here, and then you have here a typical atrophy of the adductor digiti minimi muscle. It's very important to remember that the peripheral nerves are not very, don't like pressure. Even with low pressure, you can see already a compromise of the venular epidural blood flow. And with high pressure, you can have acute block of the nerve conduction. That is very important to know. The pathophysiology can develop within hours, including inflammatory reactions. And we have different stages of these pathology evolving quite rapidly. But peripheral nerves are basically quite simple in the answer on pressure or injury. We can have demyelinating diseases as well as Wallerian degeneration. So these were my cases. However, there are further examples for nerve imaging, including, for example, staging of diseases such as neurofibromatosis, where we use whole body imaging. There are multiple tumors which can affect peripheral nerves, some of which are pathognomonic, some of which are really malignant. We have not discussed this in detail. And I would like to show you as a last example of advanced techniques, the so-called technique of MR orthopan tomography, which involves imaging of nerves in the mandibular and maxilla. Here you can see the nerve around the teeth very nicely. You can see the different teeth and the nerve. And what we do here is that we do these photorealistic images for our surgeons so that they can evaluate the nerve here prior to do any intervention. And they can spare that nerve. And with this last example, I would like to close my presentation. You have learned about radiography and its current perspectives. We have reviewed the literature and I showed some practical cases. The last thing I would like to do is to invite you to the Swiss Congress of Radiology, which is held in Davos next year in June. The Congress is in English and you're heartily invited to attend. Thank you very much and goodbye.
Мы работаем в прямом эфире, это накладывает на нас определенные технические ограничения и дает нам определенные челленджи. К сожалению, сейчас у нас не получилось параллельно с лекцией слушать синхронный перевод, но тем не менее на дискуссии у нас есть достаточно много времени, чтобы обсудить все вопросы. С нами будет переводчик, и вы будете слушать, соответственно, перевод на русский язык. Господин Андрейсик, вы уже с нами в прямом эфире?
Hello. Здравствуйте.
Да, Густав, я вас вижу. Спасибо вам большое за замечательную лекцию, очень подробную, с прекрасными клиническими примерами. Рядом со мной профессор Игорь Николаевич Пронин, президент Российского общества нейрорадиологов. Я уверена, что у вас есть вопросы.
Thank you very much for your wonderful lecture. Right next to me is my colleague, and I am absolutely sure that he's going to have a lot of questions. Can I call you Gustav, please?
Thank you very much for the invitation. Thank you.
Надеюсь, вы меня слышите. Спасибо вам огромное за замечательную лекцию. Было для меня, как нейрорадиолога, я с большим удовольствием слушал и смотрел вашу презентацию.
Thank you very much for your wonderful lecture. I myself am a neuroradiologist, and it was a great pleasure for me to watch and to listen to your wonderful presentation.
Thank you very much. It was an honor to be invited.
И, конечно же, и у меня, и у коллег, которые вас слушали и видели по онлайн, есть вопросы по технологиям, которые вы используете в своей рутинной практике.
I myself and the colleagues who are listening to your lecture online, well, we all have a lot of questions about the techniques and the technologies that you use in your routine practice.
И первый, наверное, вопрос самый простой. Как часто вы в своей клинической практике используете МР-нейрографию?
The first question is probably the simplest one. How often or how frequently do you use MRN or MRI neurography in your practice?
Например, в неделю, в месяц. Этого достаточно. В день, наверное.
Let's say if we're talking how frequently do you use this technique, per week, per month, per day, maybe?
Well, we use it daily. So I have every day 1 or 2 cases, I would say. But this is because I am known as an expert, and I get these patients from the region.
В моей практике мы используем эту технологию ежедневно. В день у меня примерно 1-2 пациента, которых направляют другие специалисты. Но это происходит в первую очередь потому, что я являюсь экспертом в данной области и получаю направление от коллег.
But I also have to say that many other radiology institutes in Switzerland are now doing MR neurography. So in the last 3 years, I would say, it has really gained popularity.
Но при этом я хотела бы отметить, что в Швейцарии мы не единственный центр, который занимается МРТ-нейрографией, существуют и другие центры. При этом я отмечаю, что последние 3 года произошел рост популярности данного направления в радиологии.
Спасибо, отличная, очень важная информация.
Thank you very much. It's very important information.
Есть еще несколько вопросов, чисто технических. Вы в своей лекции пока показывали очень важный аспект использования подавления жира.
In your lecture, you showed a very important aspect of fat suppression.
В нашей клинической практике есть разные способы подавления жира.
So in our clinical practice, we use different ways of fat suppression.
По химическому сдвигу, но я обратил внимание, что вы используете технологию Dixon.
We also do it using chemical shift, but I noticed in your lecture that you were using the Dixon technology or the Dixon technique.
И мне бы очень хотелось, чтобы вы немного рассказали, какая технология более точная в оценке подавления жира, особенно когда речь идет о, например, металлических имплантах или других инородных телах, как вы показывали, пулевое ранение в зоне интереса.
I would like to ask you, which technique for fat suppression do you consider to be the most accurate one, especially when we're dealing with certain artifacts, such as metal implants or, as you had shown in your lecture, gunshot wounds?
Yeah. Fat suppression is a very interesting and important topic because it's not a uniform answer.
Жироподавление вообще это очень важная тема, и, к сожалению, здесь нет какого-то однозначного ответа.
In my experience, it depends on the anatomic region, and you need to use different type of fat suppression techniques.
На основании своего опыта я хочу сказать, что в зависимости от анатомической области, с которой мы работаем, мы должны и выбирать различные техники жироподавления.
For example, in my experience is in the plexus, cervical brachial plexus, I use very often stir technique.
Например, в моей практике, когда я смотрю на шейно-плечевое сплетение, я использую технику stir.
In the extremities, I very often use standard fat suppression. Yes.
Когда мы смотрим на конечности, на периферических нервных конечностях, то, как правило, работаем со стандартной техникой жироподавления.
And Dixon technique, I have mixed experiences. Sometimes it's working, sometimes not.
В том, что касается техники Диксона, здесь у меня опыт несколько разрозненный, многогранный. Иногда хорошо эта техника себя показывает, иногда не очень.
But I also realized in the past years that it's also very depending on the machine. If it's Siemens, Philips, GE, Toshiba or what you are using.
И в последние годы я для себя отметил, что успешное использование техники Диксона во многом зависит от того аппарата, который у вас стоит. Siemens, Philips, Toshiba и так далее.
I use Siemens and Philips mostly.
У
and
нас
it's very different.
Я в основном пользуюсь аппаратами Siemens и Philips.
Отлично. И если позволите, еще несколько вопросов, касающихся диффузионно взвешенных изображений.
And we would like to ask you a couple of questions about the DWI images.
Мы хорошо знаем, что МР-трактография очень сильно зависит от артефактов дисторции и других артефактов.
We do know that when we're talking about MRI tractography, of course, it's a lot depends on the different effects, on distraction artifacts and other artifacts as well.
Yes.
И не только мой вопрос, но и моих коллег из чата, их интересует, насколько достоверно измерение фракционной анизотропии по ходу нерва в области поражения или в окружающих структурах нерва при использовании фракционной анизотропии. Насколько можно опираться на эти данные для какого-либо клинического или диагностического заключения?
So both I and my colleagues who are sending me questions via the chat function in Zoom, we would like to ask you this question. What do you think about the accuracy of FA, especially when we are trying to look along the nerve and we're concentrating at the damaged areas? Fractional anisotropy.
So I have to, as I did in my talk, DWI is a technique which I do not use in every patient. I would say that 70% of the patients I don't even use it because the reason for the pathology is clear without DWI.
Хотел бы, отвечая на ваш вопрос, заметить следующее. Диффузионно взвешенное изображение – это не то, что я, как правило, рутинно назначаю каждому пациенту. И более того, я хотел бы сказать, что в 70% случаев, для 70% пациентов я не использую эту методику, поскольку, как правило, и без нее мы достаточно хорошо визуализируем патологию.
I use DKI or DWI in those patients where it's unclear, where I need more information, because it's time consuming if you want to do it really good quality. So I reserve it for those patients who really need it.
Я использую технологию диффузионно взвешенных изображений только для визуализации у тех пациентов, где мне требуется большее количество информации, где я сталкиваюсь с определенными затруднениями. Вы знаете, что получение диффузионно взвешенных изображений занимает достаточно большое количество времени. Это связано с тем, что визуализация получается высокого качества.
Уважаемый профессор.
And then for me, the FA value is the most important value I look for.
И здесь, конечно же, значение фракционной анизотропии для меня является одним из основных параметров.
But here again, it is important that you get experience with one scanner. So if you compare FA values from one scanner to FA values on the other scanner for the same patient, it can be different. So it's important that you have one scanner, you get experience, and then because there is no normalization, it's not a CT where the Hounsfield unit is zero always.
И, естественно, когда мы работаем с параметром фракционной анизотропии, мы должны наработать опыт, работая на одном аппарате, потому что параметр фракционной анизотропии на одной машине и на другой машине будет отличаться, даже когда мы визуализируем данные по одному пациенту. Это совсем не похоже на методику КТ, когда если у нас значение единицы Хаунсфельда 0, то оно будет 0 везде.
И еще вопрос по диффузионно-тензорным исследованиям. Используете ли вы для построения трактов стандартные протоколы, которые коммерчески доступны и установлены на ваших МРТ-томографах, или вы используете так называемые homemade или более сложный протокол, например, протокол Харди, для получения более качественных МР-трактографических данных?
Thank you very much for answering this question. And my next question refers to DTI, or diffuse tensor imaging. So when you are working with tracts, what do you use when you're working with tractography? What do you use? Do you use standard protocols, or do you use homemade protocols, for instance, Hardy protocols, to obtain a high quality image?
Yes, so most DTI studies and most of the images I have shown are results from studies or at the university where we had a lot of time and could really work deep into the case of the patient.
Да, в том, что касается диффузионно-тензорных изображений, хочу сразу вам сказать, что большинство исследований, посвященных этой методике, проводилось в университетах. Я тоже проводила исследования в своем университете. Это все-таки были исследования, то есть это означало, что у нас было достаточно времени для того, чтобы аккуратно на все посмотреть, во всем покопаться.
Those cases are never first-time examinations. It's usually a case where we have already 1 or 2 examinations before, and then the patient is coming for a specific, very specific question. For example, they want to do surgery.
Как правило, когда мы говорим о диффузионно-тензорных изображениях, то пациент, который приходит к нам для получения таких снимков, это, как правило, пациент, который приходит не на первичный радиологический осмотр. Как правило, пациенту до этого уже проводились 1, может быть, 2 или 3 радиологических осмотра, и только потом пациент направляется на диффузионно-тензорную визуализацию, например, если это требуется перед хирургическим вмешательством.
And our standard protocols, they include DTI sequences which have enough quality to be enough for these questions.
В том, что касается вопроса про протоколы, я хочу сказать, что стандартные протоколы, с которыми мы работаем при диффузно-тензорной визуализации, как правило, оказываются для нас достаточными. То есть они дают нам изображение достаточного качества.
Уважаемый профессор, у меня есть очень интересный вопрос и наших коллег из чата. Он касается использования сгибательных и разгибательных проб при оценке, например, состояния нерва в конечности. Насколько эта проба вообще нужна или достаточно статических изображений для того, чтобы поставить диагноз? Есть ли такой у вас опыт?
Thank you very much for answering, Professor. I have another question that we got on the chat. So, when we are trying to evaluate the nerves of the extremities, do we need to do a flexor extensor test, a flexion extension test, or do you think it's enough for us to get a static image?
I explained in my lecture that I work closely together with neurologists. And the neurologists in Switzerland, they use ultrasound in their examination. They do clinical tests and ultrasound. And most of those patients already had an ultrasound functional test.
Вы, наверное, помните, в своей лекции я уже упоминала о том, что я работаю в тесной связке с неврологами. Как правило, в Швейцарии, когда пациент приходит с жалобой к неврологу, такого пациента в первую очередь отправляют на ультразвуковое исследование. Также невролог проводит клиническую оценку состояния пациента, то есть ко мне приходят уже пациенты после клинической оценки и прошедшие ультразвуковое обследование.
Уважаемый профессор, еще один вопрос из чата. Просит пояснить, вы в своей презентации указывали о клиническом заключении, где вы должны оценить 7 критериев. Не могли бы пояснить, что это означает?
In your slides, in your lecture, you mentioned, when you were talking about clinical presentation, you mentioned that 7 criteria need to be assessed. Could you please expand a little bit on that?
Yes. So when we do our reporting, we always describe what we see in a standard way. So we go for the anatomy of the nerve, if it's in the right location. if it's in continuity, if the fat around the nerve is intact. Maybe you translate now.
Как правило, да, я понял ваш вопрос. Как правило, когда мы подготавливаем радиологические заключения после визуализации, мы делаем это достаточно стандартизированно. Мы описываем анатомию нерва, мы описываем непрерывность нерва, мы описываем какие-то патологии, которые мы видим.
Then the next criterion is the nerve should be smooth and decrease in size.
Decrease.
Reduce the size.
Второй критерий, мы, естественно, оцениваем гладкость нервных волокон, и размер нерва, он должен постепенно уменьшаться.
Then you should always be able to see the fascicular pattern.
Естественно, всегда нужно, у вас должна быть возможность видеть вот этот пучковый или фасцикулярный паттерн.
Then the T2 signal should be similar to adjacent structures. It's a little bit higher than muscle, but not as high as vessel.
И, естественно, когда мы смотрим в последовательности T2, то сигнал, получаемый в окне T2, он должен быть похож на то, что мы видим в прилегающих структурах. То есть он должен быть чуть более интенсивным, чем то, что мы видим от мышцы.
And the last criterion is that the normal peripheral nerve should not take up contrast.
И последний критерий – это то, что контрастное вещество не должно накапливаться в непатологически измененных периферических нервах.
It is important to know that the neuroganglion in the spine, around the spine, they take up contrast, but beyond that border, they should not take up contrast.
Естественно, при этом мы должны помнить, что нейроганглионы, расположенные вблизи позвоночного столба, будут накапливать контраст, но все, что находится дальше, более дистально, не должно накапливать контраст.
So, I don't know if you can see this, but beyond this point, there should not be contrast uptake.
Я вот попыталась нарисовать, не знаю, видно вам или нет, но вот все, что находится далее этой точки, не должно накапливать контрастное вещество.
Спасибо. Ну и, наверное, самый последний вопрос. Вы в своих рекомендациях пишете о том, что лучше использовать МРТ-томографию с напряженностью поля 3 Тесла. В нашей стране, я не знаю, как в Швейцарии, конечно, большинство МРТ-томографов имеют напряженность поля 1,5. Стоит ли пробовать проводить нейрографию при такой напряженности магнитного поля? Или оставить это за 3-тесловой машиной?
Well, also in your lecture you mentioned that when you are doing MRI neurography, you're usually working with 3 Tesla machines. Well, I don't know how the situation is in Switzerland, but here in this country, in Russia, the majority of our machines are about 1.5 Tesla. Now, what do you think? Should we try and attempt to get a quality neurographic image using the 1.5 Tesla machines, or should we just abandon all hope and wait until we have 3 Tesla machines installed everywhere?
Well, the principle is, of course, you use the best equipment, and this applies always. If you only have one, you can do it. You need to spend a little bit more time, maybe more averages when you do the sequences, maybe play around with the metric image resolution, but it's surely possible.
Ну, естественно, конечно, я всегда даю такой совет, лучше работать на максимально передовом, на максимально современном оборудовании. Но, конечно, нейрографию можно делать и на аппаратах с напряженностью поля 1,5 Тесла. Возможно, вам потребуется чуть больше времени, возможно, нужно будет поиграть с последовательностью, поиграть с качеством разрешения изображения, но, в принципе, это возможно.
It may even have advantages. If you consider head suppression, if you have a 1.5 Tesla machine with a small bore, a long magnet, they have even better head suppression, but maybe a 3 Tesla machine wide bore.
Знаете, даже есть определенные плюсы в работе на аппаратах с напряженностью поля 3 Тесла. Например, поскольку у нас более протяженный магнит, он более длинный, то жироподавление на данных аппаратах будет более эффективным.
Спасибо большое за великолепную лекцию. Спасибо.
Нам в чат летят виртуальные аплодисменты. Спасибо большое, профессор Андрейсик. И к нам пришло огромное количество вопросов относительно НМО. Давайте с вами проговорим еще раз. Значит, для того, чтобы получить такие желанные баллы непрерывного медицинского образования. Первое. Мы автоматически фиксируем время, которое вы с нами проводите. Даже если вы переключаетесь между разными залами, оно все равно фиксируется. Второе. Всплывающая кнопка за весь день будет появляться 9 раз. Вам нужно нажать ее 7 из 9 раз для того, чтобы все зачлось. Третье – это ответы на вопросы. Под кнопкой плеера вы видите опрос НМО. Пожалуйста, заходите туда, но у вас есть только один. Не нужно отвечать сразу после сессии. Можете ответить в конце дня, но у вас есть только одна попытка. Соответственно, так как у нас не было перевода, давайте пройдемся. Для нейрографии характерна визуализация периферических нервов и мышц, которые эти нервы иннервируют, соответственно. И, как только что сказал профессор Андрейсик, вы не обязаны использовать трехтесловые машины, используем, даже если есть 1,5 Тесла, можем использовать 1,5 Тесла. Контраст не является обязательным и облигатным, и никаких специализированных катушек не требуется. Я думаю, что я дала вам исчерпывающую информацию для НМО. А сейчас мы смотрим партнерский ролик. Оставайтесь с нами.
Который мы проводим совместно с компанией Canon Medical Systems, и он будет посвящен